Now, I recently got diagnosed with Parkinson's disease. The neurology, as part of the exam, had me do all these kind of funny exercises, tapping my fingers and my feet. How do you, as a clinician, get to the diagnosis of Parkinson?
It is interesting that Parkinson's disease remains what we call a clinical diagnosis, which means that we make the diagnosis on the basis of what we see and what we hear, and not on the basis of a blood test, for example, or an imaging marker or anything like that. And what we look for characteristically is something we refer to as bradykinesia, which means slowness of movement. That's really the characteristic feature of Parkinson's. And so when your doctor asked you to tap your fingers, he was looking for a slowness in movement or a reduction in the amplitude of that movement. And that can be very subtle, but that can be enough to give us a clue that that's really what's going on. And then, of course, when you add other characteristic features like a tremor, a typical tremor when the limb is at rest, those are the two characteristic features of Parkinson's disease: slowness of movement, a tremor, and then something referred to as muscle rigidity or stiffness. Doesn't always have to be present, but when it is, it's characteristic of Parkinson's. There are a lot of other symptoms. Those are the early subtle things that we look for in a patient like you. So then your doctor may have asked you to walk down the hall. What were they looking for? Well, they were looking for a subtle asymmetry in your arm movements, in your arm swing, to see whether one arm swung normally while the other was reduced. Those are early features of Parkinson's. And it's a clinical diagnosis, so there's no test per se that says a patient does or doesn't have Parkinson's disease.
So it's not like you could do an X-ray or a blood test. There's really no way of a confirmation of the diagnosis?
Well, we've been looking for, obviously, a biological marker, a test of sorts for many years. Turns out right now we have an imaging modality referred to as a DAT scan. This actually is an indication of dopamine activity in the brain, and dopamine is the chemical that is deficient in patients with Parkinson's disease and responsible for some of those characteristic motor features that we talked about. And this DAT scan gives us an indication of what those levels are and if they're abnormally low. So that's relatively new. It's not necessary in most instances, but if there's a question of what kind of tremor the patient has or a question of the diagnosis, sometimes a DAT scan can be useful.
Now, when you look at the results of the DAT scan, does the DAT scan tell you how far the condition has progressed? Can you kind of score me on a scale of 1 to 100, telling me how bad my condition is?
We really can't do that right now. The DAT scan is not used as a sequential measure of progression. So it's not really what we call a biomarker of Parkinson's progression. It tells us that there is or there is not a dopamine deficiency. It doesn't tell us anything about prognosis. Doesn't tell us anything yet about, year to year how a patient's going to do, but it does indicate that there's an abnormality in dopamine. Where it potentially may be more useful is actually in patients who don't yet have symptoms, but who have a markedly abnormal scan. Those patients may be considered at risk for developing clinical symptoms. So it may be very much more important in sort of the early preclinical detection of Parkinson's than it is as a differential diagnostic tool right now.
So speaking about this early detection, just hypothetically, if you had lived in our household with me 5 or 10 years ago, what would have been an early indication, an early warning sign that I'm about to develop this condition?
Well, this is where a lot of attention is directed today, because we feel that the future of treating conditions like Parkinson's will be in its earlier and preclinical detection. And it turns out there are some clues. For example, patients with Parkinson's disease often have a marked loss of their sense of smell. And that loss of smell can occur many years before they develop motor symptoms. Patients can have something called REM sleep behavior disorder. This is a condition of sleep where patients will act out their dreams and flail at night and scream, and bed partners will often complain. Well, it turns out that patients may have that condition 10 years before they develop the motor symptoms of Parkinson's disease. Now, not every patient who has that sleep disorder is going to get Parkinson's, but it's a clue. It's an indication that that patient may be at risk. Simple things like constipation, depression seem to occur more readily in patients with Parkinson's before they develop Parkinson's than in other patient populations. So all these things may give us a clue as to a patient who's at risk for developing Parkinson's disease. Why is that important? Because ultimately, those are the individuals that we are going to want to intervene in. We're going to want to find therapies that can slow the progression of Parkinson's, and we're going to start in individuals before they develop motor symptoms. So it's a very interesting time in the development of new therapies and new approaches to conditions like yours.
Now, the thing as a patient I worry about most, of course, is what's going to happen next, right? So the condition is called a neurodegenerative disease, so that fancy way, I guess, of saying that things get worse over time. But can you give me a prognosis in any way?
The important thing to realize, and you're right, first of all, using the term disease or neurodegeneration is very threatening to patients as it is to you. I don't like to use those terms because the bottom line is that there is so much heterogeneity, so much variability for each individual patient that in general, when I see a patient like you, I mean, you've barely begun treatment, you've got very mild symptoms, you're active, you're athletic. Those are very good indications that Parkinson's will have a minimal impact on your life for a long, long time. And we haven't even really begun to treat you. And with current medical therapies and surgical therapies and all the therapies that we have, I look at someone like you and most patients with newly diagnosed Parkinson's, and I paint a very optimistic picture that you're going to be able to live a rich, full, and normal or close to normal life for a long, long time.
If you see me now over the next year, 2 years, 3 years, how long do you need to kind of update that prognosis? I mean, some patients, I would imagine, have more problems sooner. Some patients do well for a long time. When do you know? What are you looking for?
Well, prognosis is still very much an art in this business, but there are some general concepts. For example, patients who have unilateral symptoms that are mild and persistent, patients that have a predominance of tremor, patients that are basically younger and healthier, tend to do better in the long term. That's compared with patients who have marked slowness of movement, bilateral symptoms, trouble with gait and balance early on in the course. Those are the patients that tend to have more difficulties going forward. And that may take a few years to determine. But in general, given our therapies that we have available today that you'll hear about in later modules, we're very successful at treating the motor symptoms of Parkinson's for a long time.
Well, thank you so much, Dr. Stern.